Welcome students. Today we are going to see Ocular Drug Delivery System Part 2, which deals with all the barriers which act during the ocular drug delivery or ocular drug transport. So intraocular barriers and what are the methods to overcome that we are going to learn. So as we have discussed already in part 1 that eye is a very complicated and sophisticated sensitive part, and the anatomy and physiology is in such a way that it hampers or hinders the penetration of the drug inside the ocular tissue. Okay, so significant challenges are posed by various ocular barriers which are inherent due to the unique anatomy and physiology of the eye. So what is the use of these barriers? The major function of these barriers is to protect the eye from the toxicants. Okay, if by chance anything goes into your eye, it should not directly reach the ocular tissue. Okay, so for that the nature has devised our eye in such a way that to protect it from any toxicants, its anatomy and physiology is uniquely devised or created so that nothing can pass, or these anatomy and physiological factors, they will act as a barrier. So these barriers, they are specific depending on what route of administration you are using for ocular delivery. If it is topical, if it is systemic, if it is injectable. Various formulations and pre-formulation factors are need to be considered while designing an ophthalmic formulation. So it is said that it is believed that once you instill a drug into the eye, it is rapidly absorbed, but this is not the case. Okay, several factors, they act and they hamper the drug's absorption or penetration, and hence it is going to affect the drug's bioavailability. Drug absorption through your eye, it can occur through corneal pathway or through non-corneal route. Okay, now what is non-corneal route? Corneal route means it is going to pass directly through your cornea, but non-corneal path means what? It includes sclera and conjunctiva. The sclera and conjunctiva, they are not as significant barrier for drug penetration, but they restrains the entry into the aqueous humor, which we don't want. We want our drug to go into the aqueous humor. The drug from the cornea, it goes directly into the aqueous humor after absorption. So the corneal route is most important because it will go direct, the drug will directly go into your ocular tissue, but it has high barrier property. Okay, and when you instill an eye drop, so maximum absorption will take place from the corneal route. So goal of any ophthalmic therapy is to increase the drug absorption rather than to minimize the systemic absorption. What are the different routes of administration into the eye? See, this is peribulbar route, subtenon route, subconjunctival route. This subtenon, peribulbar, conjunctival, these are injective routes. Okay, then topically also you can administer in the form of drops or eye solutions or eye gels. Then intravitreally you are going to inject the drug directly into the vitreous humor. Also you can go for retrobulbar injection. Okay, so these are the methods, and also you can target through oral route. So these are the different methods which or the routes which are used for drug administration into the eye. See, for topical, this is topical administration, and these are the different sites of injection. This is intravitreal, this is periocular, this is systemic administration. Now let us see topical administration. Topical administration means what? You are going to instill it on the surface, any dosage form you are going to instill it on the surface of your eye. Okay, so basically these topical administration route is used to treat anterior segment diseases. Okay, the site of action is different layers of the cornea, conjunctiva, sclera and other tissues like iris, ciliary body. So here precorneal and anatomical factors, basically the corneal related factors, they act as barriers and they affect the drug's bioavailability. Precorneal factors include solution drainage, blinking, tear film, tear turnover and induced lacrimation. Most of the instilled dosage form like solution, suspension or liposomes, they are either drained into the nasolacrimal duct or it is cleared from precorneal area before absorption. Okay, so what happens if in this case large amount of dosage form is lost and very small amount of dose is it remains on the eye and it is available for absorption, and hence many of the topical drug delivery systems, they show bioavailability which is less than 5%, okay, because of all these barriers. So it results into poor drug bioavailability. Only a few percentage of the applied dose is delivered into the intraocular tissue, while major approximately 50 to 100% is systemically absorbed. Now let us see what is the first barrier. The first barrier is tear film. Okay, now on our eye surface a tear film is constantly formed. It is in dynamic state. Okay, it is constantly replenished. Okay, so this tear film, it is located on the cornea. Its role is to maintain the layer of the fluid on the eye. Okay, so it prevents drying out of the eye. So this is the tear film. It consists of mucus layer, water, and the outermost layer is oily. Okay, so it is the first resistance, and it has high turnover, means it as I told you, it gets replenished. So its composition and amount, they determine the health of the ocular surface. Mucin is present in the tear film, and it plays a protective role by forming an hydrophilic layer which moves over the glycocalyx of the ocular surface and clears the debris and pathogens. The tear volume, which is considered, is approximately equal to 7 microliters, and the cul-de-sac can transiently contain around 30 microliters of the eye drop. Okay, so if blinking does not occur, then our eye can contain this 30 microliters of the dosage form on our eye surface. Okay, the tear film turnover is said to be around 2 to 3 minutes, and mostly due to this turnover the drug is washed off, and so the drug remains on the eye surface for only 15 to 30 seconds after instillation. Okay, so the contact time is very less, and because of this very less contact time, drug absorption is hampered. So and because drug absorption is hampered, the bioavailability is for topically applied drugs is less than 5%. Now how we can overcome this? We can go for increasing the viscosity of the eye drops, or we can use gels. Now there are products in markets which are available directly in the form of gels for eye installation. We can go for sol gel formulation system. Sol gel formulation system is the system which is in solution state at room temperature, but after installation into the eye cavity it will form a gel. Okay, because of physiological temperature, or because of physiological pH, or because of the ions which are present at that point. Okay, then we can use a mucoadhesive polymer. Now what is the role of this mucoadhesive polymer? See, this is the polymeric chain on the dosage form. These are the mucin chains which are present on the mucous surface. Okay, so when this solution will come in contact with this mucin, it will form a bond. Okay, and because of this bond, this dosage form will reside on the surface for a long time. Okay, it won't get washed off because of the tear film turnover, and if it remains on the surface, then drug release will be sustained and good absorption will be obtained. For hydrophobic drugs, cyclodextrin complex can be used. Okay, now what does happen if drug is given like that? It does not it does not get absorbed and it is washed off. Okay, now if you combine this drug with the cyclodextrin, then what will happen? This combination will take the drug across the tear film, and from this complex the drug will be released into the cornea so that it will be available for absorption. So this is the use of cyclodextrin. Okay, now let us see the corneal barriers. We have seen that cornea is the major barrier or which acts. Okay, so this, if you see this small section of cornea, this cornea, it contains of 5 layers, basic 5 layers. The first one is this epithelium, next is this small Bowman's layer, then this is stroma, this is Dissemin's membrane, and this is the endothelium. Okay, now this epithelium it contains almost 90% of the cells, okay, of the ocular cornea. Okay, and these cells, they are attached very tightly, and because of presence of high number of cells, this epithelium, it is lipoidal in nature, whereas the stroma, it contains collagen matrix, and it is hydrophilic. Okay, so whenever you instill a drug, at that time it has to pass through this lipophilic membrane and through this hydrophilic membrane. Okay, so this is the major barrier. So we can overcome this by using a drug which has well lipophilic and hydrophilic balance. Okay, so now let us see this. So the cornea is the anterior most layer of the eye. It is mechanical barrier which limits the entry of exogenous substances into the eye and protect the eye tissue. It is divided into epithelium, stroma, endothelium. Each layer has different polarity and act as potential rate limiting structure for the drug penetration. So the corneal epithelium is lipoidal in nature, which contains 90% of total cells, and it poses significant resistance for permeation of topically administered hydrophilic drugs. Okay, also this superficial corneal epithelial cells, they are joined to one another by desmosomes and are surrounded by ribbon like tight junctional complexes. Okay, because of this tight junctions, hydrophilic drug cannot pass by paracellular pathway, and it cannot reach the inner layer of the cornea. The stroma, it contains 90% of corneal thickness, and it is made up of extracellular matrix and consists of lamellar arrangement of collagen fibrils. Okay, so they are hydrated, and it poses a significant barrier for permeation of lipophilic drug molecules. The corneal endothelial junction, it is leaky, and it facilitates the passage of macromolecules between aqueous humor and stroma. So corneal layers, basically epithelium and stroma, they are major barriers for ocular drug delivery, and it is vital to understand that the permeant should have an amphipathic nature in order to permeate through these layers. Okay, so compared to cornea, conjunctival drug absorption is considered to be non-productive. Why? Because in conjunctiva, blood capillaries are present and lymphatic capillaries are present. Okay, so what happens because of this? The drug which is instilled, it will move into that capillaries, blood capillaries, and it will become available into the systemic circulation. Hence, the ocular bioavailability will be lowered. Now, how you can overcome this corneal barrier? Molecule should have right hydrophilic and lipophilic balance. We can use a penetration enhancer like cyclodestrine, chelating agent, crown ethers, bile salts, bile acids, cell penetrating peptides, amphiphilic compounds, etc. So to cross the stroma, cyclodestrine can also be incorporated. The next factor is spillage of the drug by overflow. The normal tear volume is 7 microliters, and without blinking it can accommodate 30 microliters. Okay, so now whenever you instill a drop, as your drop or topical solution is external or foreign material, your eye is going to show a reflex action of blinking. Okay, now when you blink your eye, almost 70% of the administered dose is expelled, and around only 10 microliters it remains on the eye surface, and so in this case 90% of the drug is lost and very few amount is available for absorption. So how you can overcome this? You can use high drug concentration, or you can advise for frequent administration. The next factor is nasolacrimal drainage or systemic drug absorption. Immediately after dosing, most of the drug is lost due to the nasolacrimal drainage. Now in our eye, lacrimal ducts are present, okay, on the upper and the lower side. So what happens whenever a drug is instilled? It moves into that duct, okay, and that duct is connected to your nose. So the drug or the solution, it goes into your nasal passage, and through the nasal mucosa it is absorbed. As nasal mucosa is highly vascularized, 100% of the solution is absorbed, and due to this what happens, the drug, it goes into your systemic circulation. Now once your dose, it goes into your systemic circulation, it is going to show you some side effects. Okay, so so this is it. So how you can avoid nasolacrimal drainage? The first thing what you can do is, instead of going for topical administration, we can go for injections. Okay, beta 1 beta 2 antagonist and thimonol, okay, they which are used in the treatment of glaucoma, they have high risk of systemic absorption due to nasolacrimal drainage. Okay, there was one study in there was one case where timolol resulted in death of 32 patients due to bronchospasm and cardiovascular effects. Okay, now the next barrier is conjunctival absorption. As I have already told you that conjunctiva, it is very rich, or we can say it is highly vascularized. Okay, so the drug from your conjunctiva, it goes into those capillaries and it becomes available in the peripheral blood system. Okay, so we can overcome this by using penetration enhancer or use of liposomes, neosomes, nanoparticles, mucoadhesive polymers. Okay, the next barrier is enzymatic metabolism. Various esterases, peptidases, proteases and other enzymes are present in ocular tissue, including the cornea. Now, and if enzymes are present, then they are going to cause metabolism of the drug. Okay, so it may operate before absorption or after absorption. Okay, so the drugs which are highly sensitive to enzymatic metabolism are pilocarpine, levobunolol, epinephrine. Okay, so it results, due to this metabolism, there occurs loss of the drug. So enzymatic transformation of ocular product in corneal epithelium, it can be utilized for releasing active ingredient. So we can instill a product into our eye, and because of its metabolism, it will get converted into active compound, and this active compound will be absorbed, then it will be available. Okay, so corneal epithelium, it contains ionic channels that are selective for cations over anions. Now how we can overcome this? We can use the injection pathway. Okay, now let us see the physicochemical properties of the drug. It also affects the the charge of the drug molecule also affects its permeability across the sclera. Positively charged molecule exhibit poor permeability due to their binding to the negatively charged proteoglycan. Okay, so the transcellular or intracellular pathway is the main route for drugs to penetrate the corneal epithelium. So basically this paracellular route is used by hydrophilic drugs to move. So suppose this is a hydrophilic drug, it will move through the paracellular pathway like this. Okay, transcellular route is utilized by lipophilic drugs. Okay, so this drug will move transcellularly. Topically applied drugs, they diffuse, okay, against the concentration gradient either transcellularly or paracellularly. Okay, so this is the main permeation mechanism. Lipophilicity, solubility, molecular size and shape, charge and degree of ionization also affect route and rate of permeation. Solubility is dependent on pK and pH. So as we know that only ionized unionized form gets absorbed, so we can adjust the pH of the formulation in such a way that it will be suitable for ocular delivery, as well as it won't show maximum ionization of the drug. Okay, then lipophilicity is important characteristic. The drugs which show log p value in the range of 2 to 4, they result in optimal corneal penetration. Okay, then for hydrophilic drugs, major pathway is paracellular route. The tight junction in the apical cell layers have diameter less than 2 nanometers, and the molecules with less than below 500 Dalton are allowed to permeate. So the permeability across stroma is dependent on the molecular size. Now let us see what are the barriers for systemic administration. The major barrier is blood aqueous barrier and blood retinal barrier. Blood aqueous barrier and blood retinal barrier are the major barriers for anterior and posterior segment respectively. Now this blood aqueous barrier, it contains of two cell layers. Okay, it is located in the anterior segment. The first is the endothelium of the iris or the ciliary blood vessel, and second is the non-pigmented ciliary epithelium. Okay, so both these cell layers, they express tight junctional complexes and prevent the entry of solutes into the intraocular environment such as aqueous humor. The next is blood retinal barrier. It acts in the posterior region of the eye. It is composed of two types of cells, retinal capillary endothelial cells and the retinal pigment epithelial cells. So these RPE, they aid in biochemical function by selective transport of molecules across photoreceptors and choriocapillaries, and it maintains the visual system by uptake and conversion of retinoids. However, these tight junctions, they restrict the intercellular permeation. So specific oral or intravenous targeting system are needed to transport molecules through this choroid into deeper layers of the retina. So recent advancements in nanotechnology have helped to find ways to overcome the blood retinal barrier. Okay. So scientists have done some studies where they found that 20 nanometers gold particles, they could pass easily through this blood retinal barrier. Whereas for the molecules which has particle size of 100 nanometers, they could not pass. Okay. So now let us see oral administration. Oral delivery or in combination with topical delivery has been investigated for different reasons. Oral delivery was studied as a possible non-invasive and patient-preferred route. Okay. But it has limitations. It is limited by the accessibility to many of the targeted ocular tissues. Okay, and here also the two barriers which act as are those aqueous blood barrier and blood retinal barrier. Okay, so because as high amount of or high concentration is needed, there occurs systemic side effects. For example, in glaucoma therapy, oral carbonic anhydrase inhibitors like acetazolamide and ethoxylamide, they have been discontinued in most of the cases due to systemic toxicity. Okay. Now let us see what are the barriers for periocular and intravitreal administration. These two routes, they don't have, they are not much patient compliant, but these are employed to overcome the inefficiency of topical and systemic dosing. Okay. So periocular route, it includes subconjunctival route, subtenon, retrobulbar and peribulbar administration, and is comparatively less invasive than intravitreal route. Okay. So the drugs which are injected by periocular injections, they reach the posterior segment by three pathways: transcleral, systemic through choroid, and anterior pathway through tear film, cornea, aqueous humor, and then vitreous humor. So the subconjunctival route, it is rate limiting for permeation of water soluble drugs, and transcleral is route bypasses cornea and conjunctiva. So dynamic barriers include conjunctival blood and lymphatic circulation. We have seen this. The formulation goes into the systemic circulation, thereby lowering the ocular bioavailability. Okay. So drug elimination from the subconjunctival space becomes a major determinant of the vitreous drug level following its administration. So the molecules which escape this conjunctival vasculature, they permeate through sclera and choroid. Okay. Now sclera is not much barrier. And permeability through sclera is independent of lipophilicity. But choroid, it contains high vasculature, and drug is lost through systemic absorption. Okay. So this were all about the barriers which act at different points, or barriers for different route of drug administration through ocular pathway. Now in part 3 we will learn about the novel formulations which are used to overcome these barriers. So that we will see in part 3. Thank you.